Dr. Irina Stanisil provides care for children of all ages with a variety of urological disorders. She received her medical degree from Baylor College of Medicine and completed her residency in urology at Wake Forest Baptist Medical Center and pediatric urology fellowship at Texas Children's Hospital in Houston. Her specialties include fetal urology, bladder bowel dysfunction, complex hypospadia repair, Poon-Relly syndrome, and quality improvements for pediatric urology. Dr. Stanisil has been a EBF3 HADS advocate since the syndrome was discovered and maintains a large caseload of HADS patients. In addition to her medical degree, Dr. Stanisil holds a chemical engineering degree from University of Texas, Austin, and spent 2 years as faculty member at the University of New Mexico working with underserved populations. Please welcome Dr. Irina Stanisil.
I usually come and kind of give a talk on the implications, the urological implications for HADS patients. And I'm still going to do that because I imagine there are families in the audience who have not heard me talk before. And I also just want you guys to have these slides and this information just kind of set aside if anybody needs to refer to them later or anything. So I'll do that. But what I really wanted to do is to empower you to understand urological testing more than anything, a little bit on symptoms, a little bit on treatment options. But I really wanted you to, when you go see your doctor and you get some testing done, to know what you're looking at and what is being tested and what things are. So we'll go through anatomy and physiology and the conditions that are associated with HADS, signs and symptoms, things that should be concerning to you guys when you should seek care. And certainly, in spite of me telling you a whole bunch of information, I don't want you guys to all become urologists. If your child is sick, take your child to the doctor. That's the main thing. But I do want you to have an understanding of what's going on so that you can feel good about that and so you can advocate for you or a family member, of course. Like I said, we'll go through a bit of the treatment options. So this was the inspiration for this talk, is this text message exchange with mom in the HADS family. And it was after her child had a urine analysis, and she took a picture and was like, Billy Rubin has never shown up before. What the heck is going on? And I was like, Billy Rubin's nothing. So honestly, I remember this conversation being a little more colorful, so not as entertaining as I hoped it would be, but I think she can do better next time. So a little bit on just basic anatomy so you can understand the talk. So typically people are born with 2 kidneys. Kidneys do a whole bunch of stuff. And in doing all the things that they do, they produce urine that heads down these tubes called ureters into the bladder and then out into the toilet through the urethra. The function of the bladder and the urethra, they work together. So there should be synergy between the bladder and the urethra. So what you would like is when we're all kind of sitting here chatting, we're not actively trying to go to the bathroom, the urethra, the sphincter should be closed. The bladder should be nice and relaxed and able to hold urine. And it should be able to have a good capacity. So the wall of the bladder should be able to relax nicely and hold a whole bunch of urine without being small and high pressure, because that puts pressure on the kidneys in turn. And the urethra and the bladder should be working together to do their job. And then when you're trying to go to the bathroom, the urethra should open and the bladder should squeeze at the same time so that you can get the pee out. And there should be a good contraction of the bladder while the sphincter is relaxing nicely. So that is synergy between the bladder and the urethra. So in HADS patients, and I'll go in a little bit more detail later, but the punchline is the biggest problem in HADS patients is that there is no synergy between the urethra and the bladder like there should be, or there's some, but there is not an ideal optimized emptying of the bladder. So during filling, there doesn't seem to be a big problem. The bladder seems to be able to hold urine. The sphincter is closed, but when it's time to empty, the urethra does not relax when the bladder is squeezing and trying to get the pee out. and it seems to be worse in some patients than others, seems to be worse in the girls than in the boys. It can be a little bit of a problem where you'll see it may be a little bit difficult for patients to empty. So they might not be able to fully relax, but they can relax some, and their bladder can kind of squeeze and overcome that, or it can be pretty profound where they're just really not relaxing and not letting the pee out. Yeah, okay, so I'll leave it on this slide for just 1 second there. So yeah, that's basically on the left-hand side, a picture of the bladder in the filling state where you've got a closed urethra, relaxed bladder, and then in the emptying phase where you've got a relaxed urethra, bladder is squeezing. But I think you got the gist of it just from my explanation of it. Okay. So reported urological conditions in patients with HADS. So these are a couple that I'm not going to go into great detail on. I'm not sure how much more prevalent they are in HADS patients versus the general population, but maybe it's something to kind of touch on just if you have kids, because honestly, it's just a high prevalence of seeing these issues. So undescended testicles reported, micropenis, meaning a penis length less than about 2 centimeters, in the very tiny infant baby, and some report of decreased volume of labia, which I'm not sure what to make of that. So I'm not going to say anything about that. So as far as micropenis is concerned, this is a penis length of, like I said, less than 2 centimeters. This is something that if your baby boy is diagnosed with this, testosterone injections can be helpful to increase the size of the penis and really to have a long-term benefit of that. So it's not just that it increases the penis size temporarily. No, some of the benefit is really long-lasting and stays. It's a little bit difficult to distinguish between just kind of how the penis looks and whether or not it actually truly the corpora is actually smaller. So if there's a diagnosis of a micropenis, a urologist should be involved, not even just like, I would say not even a pediatrician or endocrinologist. Sometimes I've seen them miss the fact that the anatomy, just the way things look, can be a little bit tricky. So a urologist should be involved with this diagnosis. Undescended testicles, super common. 1% of the general population. That's a lot of little boys with undescended testicles. It's a lot of surgery I have to do for this. They are diagnosed based on physical exam, not based on imaging. So sometimes people will try to get a scrotal ultrasound or try to get a CAT scan or something like that, and they're just not that helpful. What you really need is a physical exam by a trained professional, by a urologist, to diagnose whether or not a testicle is truly undescended. A scrotal ultrasound will hurt. It's not a bad thing to do. There's no radiation. It's pretty easy. So if somebody tries to get an ultrasound on your baby boy, that's fine. It's just not particularly helpful. Ultimately, just go see a urologist. The reason it's not helpful is because retractile testicles are a thing and they're a variant of normal. So testicles can be in the scrotum, but sort of bounce up and down between the scrotum and the inguinal canal, depending on temperature. So if you've got a child in a warm bath and the testicles are hanging loose at the bottom of the scrotum, no problem. You can see them, you can feel them, they're right there. And then at other times they're not there. That's a retractile testicle. That's a variant of normal. So when you have an ultrasound done on that, for example, the boy might be cold, might be scared, testicles might get pulled up, you'll get a result back that reads as undescended testicle, when in fact they're not undescended. They're just fine. If they are truly undescended though, they are not in the scrotum, they're not coming down, they're in the inguinal canal, and they're kind of happy being there, those boys do need surgery, and it is a surgery that should be done pretty early, before 2 years of age, in order to really increase the chance of the testicle being healthy, decrease the risk of malignancy, of cancer, and protect fertility. The things that I think are a lot more pertinent to the HADS community are things that have to do with the health of the kidneys. So a lot of diagnosis of vesicoureteral reflux, meaning that the urine, when it gets to the bladder from the kidney, it can go back up into the kidney. It should really, once the urine comes from the kidney into the bladder, it should be a one-way street just out the urethra. So if it goes back towards the kidney, that's reflux. That's not normal. So there is a diagnosis of this in a lot of HADS patients, but the location of it is a little bit different than the general population. Certainly recurrent urinary tract infections, which are pretty prevalent just in the general population, but certainly more so in the HADS population, and incontinence for the reasons that we talked about earlier. If you have an inability to fully relax your sphincter when you're contracting the bladder, you may be walking around with the full bladder at all times and sort of leak urine. You may be developing some overactivity of the bladder from the bladder being so overworked from trying to squeeze that pee past that tight sphincter. And really what the underlying issue is that causes all these is a picture of a neurogenic bladder, meaning that the bladder isn't functioning properly, and that is what causes all the other problems. So some little kids are born with reflux. They're peeing fine. They are filling their bladder fine. They're emptying their bladder fine. So that part's not a problem, but they are refluxing urine into their kidney when they pee. The problem here is different. The HADS patients aren't necessarily, most likely not born with reflux. They're not randomly pushing urine up into their kidney, even though they're peeing just fine. The problem is at the level of the outlet. They're not relaxing their urethra to fully empty, and that in turn puts pressure in the bladder and pushes the urine up towards the kidney. So it's a secondary reflux, not a primary reflux problem. So that's where I think things could get a little bit tricky, is with the lack of appreciation for the fact that HADS patients are not reflux patients. They're not UTI patients. They're more of a neurogenic bladder patient, like spina bifida patients or spinal cord injury patients, and more complex patients who have issues with their filling and their emptying of the bladder, not just, I got a UTI, I have the, recurrent UTIs, what's going on? Should I take some antibiotics or what? There's a little bit more to think about and to address there. But really, there's a bit of a difference with the HADS presentation in that their presentation is very specific, with their issue being this urethral relaxation. But that's really the main bit of information that is good to know. And beyond that, any urologist should be able to address this, because urologists take care of neurogenic bladder in complex patients all the time. That's what we do, all of us. What makes me different is I've been exposed to a few more of you, and I know this kind of HADS patients have this very specific kind of neurogenic bladder picture, but what HADS patients do, a lot of spina bifida patients do also. So I don't want you guys to feel like you can't get good care and can't have somebody who understands your child out in the community anywhere, because that's not true. There's a little bit to it where it's like, oh, this is a little bit different in HADS patients, or this kind of very specific variant, but it falls under the umbrella of this voiding issue in neurogenic bladder that we are very used to managing as urologists. So you most certainly can get good care from a urologist who has just general exposure to treating neurogenic bladder patients. What would not be good is to have somebody maybe who's not a urologist, a pediatrician or something, who is trying to take care of a HADS patient without understanding the complexity here, and maybe just like continuously treating infections without addressing that, well, there's more going on. That would really be where I would want your child to get a little bit more specialized care. We'll skip over that. So what are some of the things you might see? So you might see wetting, daytime or nighttime wetting. And again, that would largely be due to things like overflow incontinence, because the bladder is not being fully emptied, or due to the irritability that is created in the bladder from having to squeeze past that tight sphincter all the time. A lot of kind of an interrupted urine stream. So for your children who are voiding volitionally, who are voiding by themselves, they're going to the bathroom, they're emptying, but they may have to try extra hard to get their urine past that tight sphincter. So you might see an interrupted stream. You might see difficulty initiating the stream. You might see them not go to the bathroom very frequently. These things, all of these issues tend to cause urinary tract infections. And the problem, the real issue, is when the urinary tract infections are bad. So urinary tract infection just means infection
Talking?
urinary tract, but that can be broken down into bladder or kidney infection. Kidney infection typically presents with a fever, typically high fever, 101, 102, 103, something like that, flank pain, nausea, vomiting, more kind of systemic symptoms. If you're in the audience and you're an adult, you've ever had a UTI, you know, it hurts, burns to pee, you might feel uncomfortable, but you don't generally feel like you have a flu. With kidney infection, you typically feel like you have a flu. It might also hurt and burn to pee, but you feel sick. And some of the same issues that we see with the bladder, we also see with the bowel. So in the same way that patients have a hard time relaxing their urinary sphincter, they might have a hard time relaxing their anal sphincter so that they can have a proper bowel movement. So while constipation is rampant in just the pediatric population, well, and all adult population as well in this country, everybody's constipated. But in HADS patients, I think a lot more of it has to do with that difficulty with relaxing the sphincter and emptying the bowel, and less to do with how hard the stool is. Like a lot of people think constipation is hard poop, and that's true a lot of the times, but sometimes I find in HADS patients, it's not that their poop is that hard, they have a hard time getting it out, which in turn can make it hard because they have a hard time getting it out. I doubt you'd see a lot of prenatal abnormalities on ultrasound in HADS patients. I think it takes a while for them to kind of develop and present. So the meat of the presentation here, the investigation. So I want you guys, and this, I'll make sure that you guys have these slides later so that you can keep them for your record if you want. So if your child ends up getting any of these urinary tests, you're like, oh, what's going on? Why is this abnormal? You can pull one of these up and at least get a little bit of information while you're waiting to talk to a physician. I don't know if this is national or if it's just in Texas, but definitely all of our or most of our testing, the results are released to the families right away. It used to be that a physician or a medical professional had to review things before you guys could like log into a MyChart or something and see them. And now everything goes to you. And a lot of that is good, it's great, but some of it can create a little bit of anxiety because sometimes you guys get results before we even do. So especially if it's, you know, like pathology, that can be very concerning or something like that. I do find that bit a little bit stressful. So maybe just at least while you're waiting to talk to somebody, have a little bit of this information and know why we're getting this testing. So if you ever take your kid to, or you go, anybody goes to the doctor to be checked, they have a urinary tract infection. A urine analysis is typically the first thing that is sort of checked. And that's the little dip. They take the urine and dip it to see a bunch of information there. And then some information we get later, but what's usually right away in the office, what you can get is this. And this is what we check for. So what is on here? So glucose, that's sugar. You should not have sugar in your urine. If there's a small amount of sugar, sometimes that's you know, can be a false positive or something like that. You know, worth rechecking, but it's very rare. Honestly, that's mostly should be negative. There should not be sugar in the urine. Sugar in the urine typically means consideration for diabetes, either type 1 or type 2 diabetes, the insulin type. Protein in the urine, also we should not have protein in the urine. One of the function of the kidneys is to hold on to things and not let us lose them in the urine. And one of those is protein. So if you see protein in the urine, that can be a sign of kidney disease, but it can also be a sign of a whole bunch of other things. It's not a reason to panic right away, because most of the time it actually is not significant. For example, if you have a UTI and you have some blood in the urine or some irritation, that blood can break down protein in it, and then you can end up seeing some of the protein in the urine. Also, just dehydration, fever, exercise, those sorts of things can present with a little bit of protein in the urine. So any of that can present with a little bit of protein. If you see it on there, it's definitely worth a repeat. Bilirubin and urobilinogen, typically insignificant. Most of the time, these are false positives just because of the color of the urine and the way that picks up. And as you can see, it's one of the few things on, all of these can be false positives, but this is one of the few that on there where the test even tells you, like, please know that this can be a false positive. The color of the urine has a lot to do with this, and it typically doesn't mean anything. It can be liver disease, but I can't even tell you a single time where I've seen a little bit of bilirubin in the urine and it actually turns out to be anything. Usually if they have liver disease, they present with a whole bunch of other things before you'd even get to the UA to check this. pH of the urine varies widely, and it can vary widely from meal to meal, from hydration status to hydration status from day to day. So I definitely don't put a lot of weight in the pH, except if it is routinely on either end of the spectrum, because either end of the spectrum, if your urine stays there routinely, predisposes you to kidney stones. One kind of kidney stone here, one kind of kidney stone there, but kidney stones on either side. So that's something just kind of generally to keep an eye on. Blood in the urine, we should not have blood in the urine. Now, kids are a little bit more likely to have it than adults and have it be completely benign. Some kids just spill more calcium in the urine, and it doesn't actually even predispose them to kidney stones necessarily. They just have more calciuria, hypercalciuria, and that causes them to have a little bit more blood in the urine. It is a totally benign thing of childhood that just sort of passes, but it shouldn't be a lot of urine. It shouldn't be repeated. That deserves a workup. Things like trauma, urinary tract infections, tumors, kidney disease, all of this can have blood in the urine, but it is not something to jump to being super concerned about right away, because I would be concerned all the time if I did that for blood in the urine for kids. No, adults, painless blood in the urine, definitely not normal, should definitely seek care. So somebody who's 50, 60 years old, blood in the urine is a lot more likely to be a tumor. But in kids, it's usually not anything super concerning. Ketones can be significant for if you've got a child who's a diabetic and they have a bunch of ketones in the urine, that can be a sign that their diabetes isn't being treated very well, and that would be something to address based on that. But seeing a small amount of ketones in the urine when the sugar is negative here, and you don't have a child who's diagnosed with diabetes, usually just means they're a little dehydrated. A little hydration should take care of it. And the things that are really super important from a urinary tract infection standpoint, nitrites, that is something that is, nitrates are typically found in the urine, and bacteria will convert nitrates to nitrites. So if you see nitrites, that's pretty specific for urinary tract infection. That's not normal. Now that can be a false positive if you've given your kid the azo over-the-counter medicine for pain. If they have some painful urination from a UTI and you or your child took that medicine that makes your pee orange, that will give you a false positive on this. But otherwise, it's pretty concerning for urinary tract infection if you see it. Excuse me. Leukocytes, these are white blood cells, significant for inflammation or infection or contamination. So again, not in and of itself, not necessarily something to jump to conclusions about, but putting it together with some of the other things, now we're starting to see a pattern that can signify infection. So like here, normal is to have no leukocytes, but trace, especially in the setting of everything else looks okay, I would consider this urine analysis here to be normal. I didn't put anything for appearance and color. Obviously, those can vary depending on hydration and all that. Specific gravity, the reason that might be important is it measures the sort of the thickness of the urine. So it measures how dehydrated somebody is. So they give you a range there, and you don't want to be really on either side of it. Now, if you're just really overhydrated one day and the specific gravity is really low, that's fine, as long as it normalizes at some point. But actually, having your specific gravity be too low can be a sign of another kind of diabetes insipidus. It means your kidneys can't concentrate urine, they're just spilling too much water. And having it too high means you're dehydrated. So that's your range there where you kind of want to be, but being on either side of it temporarily is not a huge deal as long as it does normalize with a normal intake of fluid. Okay. So the most important things when I look for a sign of urinary tract infection, what my eyes go to immediately are blood, nitrites, and leukocytes. So if I'm interested to see if somebody has a UTI, if they have no blood in the urine, they're nitrite negative, and they barely have any white blood cells in the urine, that's very hard to have a UTI and have all of those things look like this. So typically in the sign of, the setting of UTI, you'll have maybe like moderate or large leukocytes. Most bacteria will turn nitrates to nitrites, although not everything, but nitrite is a very common and specific thing for urinary tract infection. And frequently the irritation from having a UTI will cause you to have some blood in the urine. oftentimes you'll take a child or you'll go to the emergency room and you get told, oh, you have a urinary tract infection. And then I see you guys later in clinic and I'm like, well, it looks like when you went to the emergency room, 2 weeks ago, he did not have a urinary tract infection. And families are like, what? But we were told he had a urinary tract infection. Well, you were told it looked like a urinary tract infection based on some of those things in the urine analysis looking concerning for urinary tract infection. But ultimately, what really tells you if there's a urinary tract infection is a urine culture. So the urine culture should show bacteria if there's a true UTI there, because some of those things, like I said, blood in the urine, even white blood cells can show up without any bacteria there. And then it wasn't really a urinary tract infection. So the confirmation for urinary tract infection comes a few days later, 48 to 72 hours later. So it's perfectly okay to start an antibiotic based on the suspicion of urinary tract infection, but the urine needs to be sent for culture and followed up on to make sure that the antibiotic that was chosen for the patient is the appropriate one, that we didn't start Keflex and ultimately, 2 days later, never mind, the patient's resistant to Keflex. That should be changed if it needs to be changed. And another little bit that sometimes comes back pretty close after it's sent to the lab, but sometimes it takes a while too, is not just looking at the urine analysis like we looked at it, but actually having somebody go and look under a microscope and verify something. So for example, on the office urine analysis, the little dip, it can come back and tell you, oh, there's a moderate amount of blood here. But that can just be a false positive from you eating beets or something. Versus on here, on a microscopic analysis, they look and they actually count. In a high power field, you should only be able to find 1 or 2 red blood cells. If you're finding a bunch of red blood cells, that's true hematuria, blood in the urine, not just that the test gave you a little bit of a false positive. And similar for the white blood cells. It's not just, trace, moderate, whatever. Like we're counting white blood cells per high power field, so it's more specific. The one thing that I wanted to point out on this that you may see, and you can also watch out for yourself, is the squamous epithelial cells. There should be really no squamous epithelial cells in a good specimen. That means you got a whole bunch of skin flora, skin stuff from outside of the urethra in the cup. So now when you're looking at what's in the cup and there's bacteria or there's whatever there, is it from the bladder or is it from the labia or from the foreskin or something? So if you're seeing a bunch of squamous epithelial cells, now you have to go back to your results for the analysis in a culture and give consideration to how seriously do you want to take them. So that's what that is about there. How do we collect specimens so that they can be accurate? So a lot of times when you take, especially a little kid who's not potty trained yet, take them to the pediatrician, they might offer, well, we're concerned for urinary tract infection. Let's put a bag on them and have them pee in the bag and we'll check the bag, the urine in the bag and see if they have a UTI. Not a great idea. As you can imagine, having a bunch of skin cells and skin flora and bacteria from around the labia and around the penis, very, very easy. So then if you get a positive culture, what do you make of it? Did that come from inside or did it just come from outside? So it can be very tricky. Now, if they do put a bag and the specimen from the bag is totally negative, oh, that's great. That's a pretty negative specimen. That means there's nothing in it. Doesn't matter where it came from. There's no bacteria there, right? But if it's positive, you have no idea. It could be a UTI. It might not be a UTI. And they'll give you antibiotics and your kid's probably going to get better. But then you're going to be stuck later trying to figure out, well, did we treat a UTI? Do I need to see a urologist? Do I need further testing that can be invasive? Like, what does that mean? You're left with poor information to make decisions. So it's not just about treating the patient right then in that moment. It is about making sure that we have good information so we can make good decisions later on. Pre-potty training, ideally the best specimen would be a catheterized urine specimen. That's the most reliable. I know it's annoying and I know it's frustrating, and even pediatricians' offices find them traumatizing for the staff and the patients involved. But believe me, in the long run, when you've got a sick child, and they're not responding to antibiotics, and you don't even have a good specimen to begin with, and you don't know what antibiotic to treat with, it can be very frustrating. So kind of, sucking it up front and going for this good catheterized specimen is probably the right thing to do. Post-body training, not as necessary, also more traumatizing. So for several reasons, if you have a 4 or 5-year-old child who is able to give a specimen, that child is going to be a lot more annoyed than a baby with being catheterized, first of all. Second of all, they're able to give you a specimen. So it is reasonable to try to just do a voided specimen, but try to get it as clean as possible. So midstream, if you can get your child to like pee a little bit in the toilet and then be ready with a cup, if you can. I know it's difficult. In little boys, if you can have the foreskin pulled back, if you can take some of those wipies and wipe down the labia, wipe down the head of the penis before they pee, so that you can get a good specimen, that's a great idea. The first little bit of urine is not the most ideal because that can have a little bit of bacteria from just like the meatus, just the tip of the urethra. So you want that's why we say do the midstream clean catch, but I know it's difficult in kids. Now, in adults, if you're trying to diagnose a sexually transmitted disease, then the first little bit of urine is ideal. But and if you're trying to look for a urinary tract infection that's coming from inside the bladder, then you want more of a midstream. Blood work. Very basic urology favorite, basic metabolic panel. If you go to the doctor, you go to an urgent care emergency room and they do blood work for any reason, you'll probably end up with this test. So I pointed out the things that would be kind of the most pertinent to me. So they usually run a blood glucose on here, which was again indicative of diabetes if it's way out of whack. And the two numbers on here that are most pertinent to urologists, the BUN and the creatinine, they're both waste products from different things. And the BUN is liver, the creatinine is muscle, but they're both things we have in the blood that are cleared by the kidneys. So that's why the numbers for how much BUN and how much creatinine is in the blood, it tells you about kidney function, because if the kidney's not able to clear these two waste products, then you end up with these numbers being out of whack. They kind of signify a little bit of a different thing. So like if the BUN is out of whack more than the creatinine, that patient's probably more dehydrated and having true kidney dysfunction. The creatinine you have to take with a little bit of a grain of salt because it's very dependent on muscle mass. So if you have a child who has less mobility, maybe an elderly patient or a tiny baby, you have to account for the fact that they don't have as much muscle mass and just take that with a little bit of a grain of salt. So typically the lab results are pretty good about giving you at least an age adjusted, if not a gender adjusted, and a further adjusted creatinine, at least an age adjusted. So like this was in a baby. So in a baby, 0.31 to 0.53 would be considered normal. Having it be less than that is totally fine, but having it be higher than that is not. That's indicative of kidney dysfunction. And it is adjusted because this would, for a baby, a creatinine of 0.9 would be way out of whack and really quite significant, versus for me, that would be totally fine. In fact, that's probably what I would expect it to be. So very dependent on how much muscle mass we have. And then a whole bunch of electrolytes that I didn't put anything about. They can, signify different things. Any of them being a little bit off is probably not a huge deal, but being significantly abnormal is, and that needs to be addressed. The potassium is a big one that we watch, especially in patients with kidney dysfunction. They can have too much potassium, and that can be significant for causing heart abnormalities and arrhythmias and things like that. So if somebody's creatinine and their kidney function is totally normal, then the potassium doesn't matter as much. But especially if somebody has kidney dysfunction, I watch that potassium closely. But frequently, it's false news. The specimen is hemolyzed. Like if they push on you a lot when they draw your blood and basically break down a lot of the red blood cells have potassium in there. So you'll get these potassium levels that are crazy high. And that's not true. That's not truly how it is. It's just the specimen has a lot of potassium from red blood cells that were destroyed through the drawing of the blood process. So again, kind of have to interpret a lot of these things, but at least you kind of have a little bit of a sense of what we're looking at. Another way of looking at kidney function that is probably better, just not as popular yet. So it's not, and it takes a little bit longer. I think it takes a little bit longer to get the blood test back, and definitely not something that will be randomly ordered in an emergency room. But cystatin C is another product that's in the blood that is cleared by the kidneys, so you can measure it, and that tells you how well the kidneys are working. It is not dependent on muscle mass. So that's kind of the best thing about it, is that it's a little bit more reliable. It's not like if you're, if you have muscle wasting, for whatever reason, you have, you're ill for a while and kind of laying around or whatever. This is a little bit more reliable. It is also a part of this complicated equation that is used to calculate your GFR, which is your glomerular filtration rate, which that really, those numbers, so down here where you're seeing these numbers in the 40s and the 50s, that really is your overall kidney function. All these other numbers, cystatin C, creatinine, BUN, are suggestive of your kidney function, versus the GFR is, okay, now we've plugged all this into a calculator and we get what your kidney function truly is, and we can sort of stage you. Is this normal? Is this stage 1, stage 2? How concerning is this kidney disease here? And a lot of the reason for me talking about this is because a lot of the goals in HADS are to prevent urinary tract infections, protect kidney health, decrease the pressure in the bladder so that we protect the kidney, so that we don't end up with abnormalities in these numbers, because we don't end up with abnormalities in the kidney function. We don't end up with scarred kidneys. So obviously, these things are important to monitor for the concerns that could occur if we don't protect the kidneys as well as we could, or in an optimized way. Imaging studies. Ultrasound, probably the most common imaging study. I consider it to be an extension of my physical exam. I think anybody who comes to me should have a renal ultrasound. I don't know that everybody feels that way. In fact, I know they don't. But especially in HADS patients, I think this is kind of a critical test to monitor what is going on. Normal kidney would be on the left-hand side of the screen there. You see it has kind of this like bean-like shape, and there's not a bunch of black in it. So black would be like if you see on the right-hand side of the screen and you see where it says bladder there, that black space, that's urine. So liquid looks black on ultrasound. So in the kidney, we should not be seeing any of that black. The urine should flow freely down into the bladder, and it should flow pretty quickly. So if it's not flowing and you're seeing a bunch of black in the kidney, there's a problem there. There's a blockage. There is reflux from the bladder up towards the kidney. There is high pressure in the bladder. So even though there's no reflux, the urine is having a hard time getting down because it's trying to go into a high pressure system. So that's not what you want to see, and that needs to be addressed and worked up if that's seen. So this is how this would look. So if you're in radiology with your kid and they're getting an ultrasound, and you're starting to see a whole bunch of this black in the middle, that's something that maybe resulted in the report as hydronephrosis or dilation or urine in the kidney. It's not, the test isn't super, like if you have a little tiny baby, the test may be a little bit tricky. So it's not, I don't want you guys like looking at these images and kind of jumping to conclusions, but if you're seeing a bunch of that black, that's typically abnormal and significant for dilation. Bladder, when you ultrasound a bladder, oftentimes it's just empty. Like if somebody just pees and then they go get an ultrasound, there will be no urine in the bladder. And the report might even say, oh, the bladder is underdistended. That doesn't mean anything. That just means the bladder is empty. It's underdistended for evaluation. They can't see it very well, so they can't tell you much about it because there's no pee in it for them to see the lining, but there's nothing wrong with that. But if there's a little bit of pee in the bladder, then you'll be able to kind of see the lining of the bladder, see the wall, see if there's anything protruding into the bladder, any mass or anything like that. And in HADS patients, I think more often than not, you're going to see a distended bladder. They have a hard time emptying, so they're full. So it'll be hard to find a bladder that's really completely empty. Debris in the bladder can mean absolutely nothing. It can just be there just because cells from the lining of the bladder are shedding, and you're seeing them more in that kid that day, especially if they're a little bit dehydrated or something. But it can be significant of urinary tract infections. So again, part of a whole picture, putting it all together. We have a child with symptoms with the urine analysis that is concerning. Now you have a bunch of debris in the bladder. Maybe you're seeing some urine in the kidney that you shouldn't be seeing, and there's debris in that too. Now you're starting to put this whole picture together. Now we're concerned for infection in the bladder, possibly in the kidney as well. This is a bladder with a vesicostomy. So we'll talk about what this is, but this is a diversion of the bladder where there's a stoma and the bladder is draining directly to the skin. And that should really keep the bladder completely decompressed. So I'll show you some pictures of that, and I'll talk about why I think that is a great idea for some HADS patients. And but this is why. When you have a bladder that is continuously drained, it is empty. And that means that there's no pressure in it. So the kidneys can freely drain their urine into the bladder, and the urine comes right out. There's no reflux of urine up into the kidneys, and there's no back pressure from the bladder backing up into the kidneys, even without reflux happening. So if you have a patient who is truly in retention and having a difficult time emptying, sometimes a urinary diversion like a vesicostomy can be a great idea. And this is why, because this is how they always look. Like, it doesn't matter what time of day you look at their bladder, it is empty. If they have a vesicostomy, it's continuous drainage. Somebody might get x-rays on your child. I think in the HADS population, the most helpful aspect of this would be to look for the degree of stool burden and to look for constipation. This is a pretty constipated child here. These kind of speckles, the way that you see like all these speckles, so that's all poop. The colon starts on the right-hand side of the body here, and it kind of goes across and across down into the bottom, into the rectum. So kind of like a question mark across the body, really. And there might be some poop like at the beginning of the question mark and coming across the top, and certainly more on the way down here. There shouldn't be a ton, if any, down in the rectum right down below the anus where you poop from. That part should not be used as a holder. When that should just kind of be empty. It should have minimal poop in it. When poop comes into that rectal area, the rectum senses distension and tells you to go look for your favorite bathroom so you can poop. So kids, and especially HADS patients, but honestly kids in general will do this, tend to hold it. They hold it down there in the rectum. In HADS patients, I think it's because they have a hard time relaxing their anal sphincter. Kids in the general population, your average 5-year-old just doesn't want to go to the bathroom anyways, so they're holding it. So I see a lot of stool in that rectal area, which pushes up on the bladder, causes bladder irritability and instability, causes urinary tract infections and incontinence. It's a huge load of bacteria right there for your UTIs, most of which are E. coli, which is straight up poop. So lots of reasons to attack constipation from a lot of different angles. And in the HADS population, definitely to be thinking about that anal sphincter and the problems they have with anal sphincter relaxation. CT scan, not necessarily something that would be ordered a lot in a HADS patient, but maybe. The best time when it would be indicated would be if you're concerned for a kidney stone. CAT scans are great at looking at kidney stones. So over here on the right hand of the screen, let's look at that first. If you see this like kind of white dot, can you all see my arrow? I don't know if you can, but I'll just describe it just in case. In the very middle of the screen and of the belly there's like an almond shaped little white dot there. That's a kidney stone, which is actually pretty substantial. And you can see it on the different slices in the left images there as well, but very easy to see, difficult to see on ultrasound, believe it or not. You see a lot of that kind of gray speckly stuff like we saw earlier, but it can be difficult to see a stone in and of itself. The ultrasound's great for looking at urine, great for looking at, do you have urine where you shouldn't have it? CAT scan, great for finding the actual stone. So different imaging modalities have different indications depending on what you're looking at, but the general population, the prevalence of kidney stones in the general population, I think it's like 11% now. And if you have urinary tract infections, you're at a higher chance of having kidney stones. And if you have neurogenic bladder, you're higher chance of having kidney stones. So if the general population has an 11% chance, I can only suspect that HADS patients have a slightly higher chance of having kidney stones, which makes it pretty darn high. So this may be something you're faced with at some point. MRI images, again, not necessarily specific for HADS patients, but kind of in general, great assessment of anatomy. So if you think that the patient has some kind of complicated anatomy where, you know, like the reason I got an MRI in this girl is I thought that she had 2 ureters draining each kidney because of how her kidneys looked on the ultrasound. And if you look up here to where her kidneys are on the image, you can kind of see this like funny shape. It's like Y shape. So if you looked at the ultrasound and looked at the kidney, you're like, gosh, is the top of the kidney draining via one tube and the bottom draining via another tube? Not quite true. They do merge and they ultimately drain into the bladder via one tube. But the MRI is the imaging modality that I needed to show me that anatomy really well. So if that's ever a concern for your child, like, is there an upper part of the kidney that's draining via a ureter that maybe went haywire and is plugging in somewhere random and weird, which is called ectopic? If there's a concern for a mass that needs to be characterized, something like that, then an MRI is great. I wouldn't be surprised if a spinal MRI is done in HADS patients, not infrequently, because their bladder looks like a neurogenic bladder that would come from spina bifida, that would come from tethered cord, that would come from a spinal cord abnormality. So when I met a HADS patient for the first time, immediately MRI'd everything top to bottom to see if the spinal cord was causing what looked like was a neurogenic bladder. And I was shocked that the spinal cord was actually fine. Usually they have a lower spinal cord problem in spina bifida. And so sometimes we'll just start with just looking at the lower part of the spinal cord. Sometimes you get the whole thing. And the spinal cord in HADS patients will be normal, but yet you still have this picture of the bladder that looks like there should be something wrong with the lower spinal cord. So I think that's part of what you guys may end up seeing for your children, and that would be the reason, because the MRI has great ability to look at that detailed anatomy of the spinal cord better than anything. A Uroflow, great little office test, not invasive, just has the kid sit or stand and pee in this little contraption, and it measures the strength of their stream. And it should be this like kind of smooth bell curve where it goes like, and then it comes back down and reaches a peak and then it comes back down. In HADS patients, what I frequently see is a bunch of peaks. Like it'll start and go, start and go, start and go, start and go. And they typically still, or often they will empty, but it just takes them a long time. So the boys will often do this where they have a hard time. They're trying, they're peeing, stop and go, stop and go. The girls are, at least the girls in my practice, are more profound than that. So they have just a hard time emptying altogether, but the boys they'll try. It just takes them a while and a few of these cycles basically. Sometimes you'll have little patch electrodes put on their bottom that actually tells you when they're contracting their sphincter. They used to use these needle electrodes. We don't do that in my clinic. I don't know if some clinics do that. I'm sure they're more specific, but it also involves having needles put in your bottom, which is not fun. Yeah, so this is just to show kind of that uroflow, that staccato pattern, that interrupted flow, indicative of this dysfunctional voiding of the coordination between the bladder and the sphincter not being what we want it to be. Avoiding cystourethrogram involves placing a catheter in the bladder and putting contrast in the bladder, and then you take the catheter out and you watch them pee and take x-rays and see what happens to the contrast. They should pee out all the contrast and it should not go back up into the kidney. So this is a very common test to order if somebody is having recurrent kidney infections. So recurrent bladder infections without fever, this would typically not be a test that is done, because that doesn't, this test looks for, is the urine going up into the kidney? Is the infected urine going up into the kidney? So if they have reflux, they typically have febrile urinary tract infections and they're getting sick and they're having kidney infections. If the child is just having bladder infections, this test isn't particularly helpful. But like this kid, we have a child with febrile urinary tract infections, you want to know what's happening when they pee. So catheter in, contrast in, and you see on the left-hand side of the screen there, the contrast is going up towards the left kidney. This is reflux there. So that is a concern for every time that child gets a bladder infection. now it's a kidney infection immediately, because the minute that their bladder is full, they've pushed bacteria right up into that kidney. So that's why reflux is concerning. Reflux in and of itself doesn't cause infections. Not really, not for the most part, not 99% of the cases. Sterile reflux isn't usually an issue. It's when you have an infection and you're pushing urine up into the kidney. That is the problem. Now, sterile reflux can be a problem, and it can most certainly be a problem in HAS patients, because again, the issue in HAS is not just that they're just refluxing, is that they also can't empty. So they have their urethra is tight, and they're using their reflux to pop off pressure. They have too much pressure in the bladder. They can't get the pee out. So now they're letting some of that pressure, they're releasing it up towards the kidney. So even sterilely, that's not great in HAS patients. Generally, I don't care about it as much, but in HAS patients, it can be an issue from a pressure standpoint and certainly from an infection standpoint. A DMSA scan is a nuclear medicine scan that looks for scarring in the kidneys. So it tells you how well the kidneys are working compared to each other, and it tells you if there has been any scarring. What causes scarring in the kidneys? Sometimes people are born with poorly functioning kidneys. I doubt that's most HAS patients. I think like spina bifida patients, they start off with good kidneys and then deteriorate over time. So, but that's, sometimes people are born with a kidney that doesn't work very well, and that's just that. There's nothing you can do about it. But what we can do something about is pressure. So like I said, if the urine is not coming out properly and the pressure is being transduced either through a reflux or without reflux, the pressure is being transduced to the kidney, that can cause kidney deterioration. And urinary tract infections, huge one. Urinary tract infections can make a kidney look like somebody literally took little bites out of it. Even one urinary tract infection can cause a kidney scar, and that kidney scar can be permanent. Now, it's not super common. Most children get kidney infections and don't have any permanent repercussions from it, but that is the trouble with urinary tract infections spreading into the kidneys, especially in little kids. The younger, the more concerning. Recurrent kidney infections in little kids, especially 1, 2, 3 years of age, we say less than 5, can cause kidney scarring, and that can be permanent. And that is the biggest reason to take all of this very, very seriously, is that we're trying to protect kidney function for the rest of their life. So the way you're born, pressure, and infections, biggest cause for kidneys not working. So like on here, you can see the left kidney on the left-hand side of the screen is fairly normal. There's maybe a little bit of a gray spot there, but the right kidney is the one that is poorly functioning for whatever reason in this child. But that's how this would look. And this is the best test to look for that. If you're concerned for kidney scarring, ultrasound may miss it if it's small, and other testing might miss it too. But this is the best test for kidney scarring. Another test that is a nuclear medicine test that probably is less applicable to HAS, but just in case you end up getting it for whatever reason, also a nuclear medicine scan, also will tell you about function and about scarring, just not as well, it's not as good as the DMSA scan, but what it will tell you is about drainage. So if for some reason they're concerned, not that your child is pushing urine up, but that there's a blockage and the urine is having a hard time coming down. For whatever reason. Oftentimes, kids can be born with a blockage right where the urine is trying to leave the kidney, or down low where the kidney is trying to plug into the bladder. But if there's somebody's concerned for blockage of the kidney, this would be the test. So you, as a side product, you get a little bit of information on function and on scarring, but it's the obstruction. MAC3 tells you if the kidney is blocked. And this is how it does so. So over here on the right-hand side of this of the little image up top, you see the right kidney is in green, and it's in green on this little graph. So there's an IV in, a tracer is given to the patient, and you can see the right kidney in green took up that tracer and whoosh, spilled it right into the bladder. So by the time you get to, I don't know, 30 minutes, certainly by 60 minutes, that kidney is done processing, excreting. It already took up that tracer and said goodbye to it. versus look at the poor left kidney. It's still struggling to even take up that tracer, and there's no excretion. Like, it's still busy doing nothing. It hasn't even put anything down towards the bladder, and the test is now going on for 60 minutes. So this is a very, very blocked kidney. This blockage was happening right where the urine was trying to leave the kidney at the ureteropelvic junction. So I'm actually operating on this kid next week. This will usually present with pain, with flank pain. Yeah, I don't think that that's necessarily more prevalent in HADS patients, but that whole idea of there's dilation and there's hydronephrosis, there's urine where it shouldn't be. Somebody might feel the need to get this at some point to make sure there's no blockage along that path of the urine. So if you see this, that's what they're looking at and how they're processing this information. Urodynamic study, super helpful to understand how the bladder is functioning. It's just invasive. So I can't tell you I would 100% just recommend it to all the HADS patients, although I would love to see, hundreds of urodynamics in HADS patients so I could better understand what's going on. But it is invasive. So I think that there's something to be said for getting it judiciously. So there's a catheter that is placed in the bladder and a catheter that is placed in the rectum. So the catheter in the bladder measures the bladder pressure, but we push onto the bladder with our belly wall. So the rectal catheter subtracts anything you're doing with your belly away from the number. So you can just get, okay, what is the bladder doing? And remember at the beginning, I was saying the bladder should be nice and comfy and stretched and holding and not putting high pressure while we're filling. It should give a good squeeze and letting all that urine out when we're done. So that's kind of what we're looking for. We typically do use, when we're filling the bladder, we'll use contrast instead of water to fill the bladder. And we also have an x-ray machine there in the room. So we're taking pictures. So we're not just getting pressure information. What's the bladder pressure when there's 50 milliliters of fluid in the bladder? But you're also getting a picture of what that looks like. So it's a whole bunch of really good information. And so if somebody's having a hard time telling, well, I don't know what the child is doing, this is what a urologist would need. So this is why I'm saying, I do feel strongly that really any good urologist would be able to take care of HADS patients, because if they're kind of feeling tricked by what's going on and they're like, okay, well, we have this neurogenic bladder type picture, the MRI is normal, what the heck is going on? If you get this test, you see, oh, the bladder is actually holding pretty well, but the sphincter is not relaxing when the patient is trying to void. So you get that information from this test that I have going into seeing a HADS patient to begin with. So, and even with me having that information, sometimes I find this test helpful to see exactly what's going on. I think as long as the testing is available to be done so that the urologist can understand the patient, they have the ability to treat the child. This is what a test would look like when we are sort of happy with the result and kind of what we want to see. The top line is the pressure measured by the bladder catheter, then the abdominal catheter, and then we take the abdominal numbers away from the top line because we don't want to know what you're doing with your belly wall. We just want to know what the bladder is doing, and that's the third line, the green line. So as you can see, we're going across the test there. We're filling the bladder with contrast, with water, with whatever is being filled with. The pressure stays super low. That line doesn't do anything. And then when the bladder gets full, then the patient's like, I have to pee. You give them permission to pee, or they take the permission. They make their own choices. They start peeing, and you see a contraction in the bladder. The pressure goes high, and they get all that pee out. So that's kind of what you would want to see on the test. This is more of what we would see in a HADS patient, is that pressure can go a little bit high. You see the green line is going increasing, and they're trying to squeeze. You see those little blips in the green line, they're going up, they're trying to pee, but at the same time, the red line right below it, you see how it's like firing. You're seeing all that activity. That's the activity in the pelvic floor, in the urethra and the sphincter. So they're trying to pee, but at the same time, they're working against themselves. So that's the issue, where you have this dyssynergy, a little bit of a toxic relationship between the bladder and the sphincter. They're not working together. They're not cooperating. And this is a picture that looks a lot like that VCUG that we saw earlier, where there was a catheter in and the dye put in, and we see that the patient is voiding here, the contrast is coming out, but it's also returning back up to the left kidney. Screening and follow-up, just based on my understanding of what is going on with HADS patients urologically, I certainly think renal ultrasound and tracking them with renal ultrasound is very, very reasonable. And I've been, saying this for years. There's no radiation. It's easy to do. We know that the issues can be very significant in HADS patients. I talked about why. The end result can be kidney dysfunction, which is a big deal. So why not look? Why not keep a close eye on them? Keep an eye on their symptoms, but keep an eye on their kidneys with ultrasound to make sure that there's nothing that is getting away from us. So I think especially in those first few years of life, every 6 to 12 months would be very reasonable. You can space it out a little bit, once a year, once they get a little bit older and they've proven a little bit of where they're going with this whole thing. But in the first few years of life, until you kind of get an idea of what's going on, ultrasounds are very reasonable. And if you have problems, if you're getting infections, if you have hydronephrosis, that dilation in the kidneys, if there's something going on that's concerning to you, then you can get that invasive testing with the catheter, either the voiding study where that's supposed to check for reflux very specifically, or the urodynamic study that has the side benefit of checking for reflux, but something to where it gives you an idea of what's going on with the bladder and are we pushing urine up into the kidneys. If you're concerned that we've had infections, maybe get that renal function study and see, are we scarring kidneys already? That's going to make you want to be more aggressive with what you do. If you're concerned for obstruction, get that test. If you're concerned for a stone, get that test. If you're concerned for the anatomy, get an MRI. Maybe consider refer to gastroenterology pretty early, because I do think that the bowel issues can be pretty significant. And unfortunately, if you let it kind of get away from you, it gets harder. Like once that colon has been really constipated and stretched out and everything over the years, it's harder to get control of the situation later than it is upfront, before issues have really started happening. Simple things to do for bladder management, and this is probably for all children: time voiding, going to the bathroom every couple of hours rather than kind of when they feel like it. I think that just should be, kindergarten 101. I don't feel like the kids want to pee anyways. So hydration, and this again for all kids, but definitely for kids who are voiding by themselves, relaxation techniques on the toilet. So you're trying to get them to relax that sphincter, to not over squeeze and over tighten. And I don't know how much that is, so that, in the general population, some of that may be within their control. Some of it may not be. They've developed a tight sphincter and it's just kind of there. And in HADS patients, it's less that likely that it's within their control at all. But that should still be something that you're trying to do with them to help them as much as you possibly can. And ways to kind of fake it is alpha blocker. So that causes the sphincter to relax some, works to some degree, I think, in HADS patients. It's not perfect, but it's something to help with that sphincteric relaxation. Anticholinergics help with bladder relaxation. So the primary problem in HADS patients, though, is the sphincteric relaxation. The sphincter is not relaxed. So if the sphincter is not relaxed, then they're having a hard time emptying their bladder. That causes bladder irritability. The oxybutynin, the anticholinergic, soothe bladder irritability. So sometimes when you get a kid in the clinic and they're having accidents, they're leaking, the instinct is to, well, let me get you to hold your pee better so you're not squeezing as much and you're not pushing out as much pee and you're more dry, which is the problem. You're taking your child to the urologist because they're wet. They have too many accidents. So they may want to instinctively do the anticholinergic to relax the bladder, but that's putting a Band-Aid on the situation. The bladder irritability comes from the initial inability of the child to empty their bladder for years. Now we have bladder irritability. So if you give some oxybutynin, some anticholinergic to relax the bladder without addressing the fact that the real issue is the sphincter is not relaxing, so when they pee, they're not peeing well, it's going to get you in trouble. They won't be able to pee at all. Now you're going to have a real problem with urinary retention. So the first thing that needs to happen in HADS patients is work on the emptying. So Flomax to relax the sphincter to help them empty. And if you need a very tiny whiff of the oxybutynin to soothe some of that irritability that has happened over time, very, very judiciously. Very easy to put a child with HADS in urinary retention, especially with oxybutynin. So have to be very, very careful with that. Oxybutynin would have great use if they have bladder irritability, so they're having all these squeezes to their bladder because they're annoyed that they've been having to squeeze against a tight sphincter for a long time. But you're catheterizing them. So if you're catheterizing them regularly, you're catheterizing them every 3 hours or 4 hours to get their urine out. In between those catheterizations, you can relax the bladder with oxybutynin, sure, because you're not worried about their voiding phase. You're taking care of that. So there's definitely a utility there, but I'd be very, very careful to just give a child with HADS oxybutynin up front, where a lot of children who have bladder irritability do take it up front. Mirabegron, great, works just like oxybutynin, except with some of the constipation side effects. Excuse me. Hellacious to get it approved by insurance. They make you try 3 anticholinergics before you start Mirabegron, and it's not off-label yet or generic or whatever it is. It should be getting off-label soon so that we can prescribe it easier, but they make it so difficult for us to prescribe for patients. But it does have the benefit of not having a constipation with it. Prophylactic antibiotics have their role in recurrent infections if you're trying to prevent urinary tract infections. The role is to keep bladder infections from spreading into the kidney. If in the setting of reflux, like we talked about, the biggest issue in reflux is that the reflux is spreading bladder infections into the kidney and causing potential kidney scarring. Oh my God. This is what happens when you bring your dog with you. And if you prevent urinary tract infections, you're preventing the infections from spreading into the kidney, you're preventing the kidney scarring that is happening from the infections. You're not preventing the kidney scarring that is happening from pressure going back up into the kidney. That can be a thing in and of itself, just like we talked about, but you're at least minimizing the risk of infection, which is minimizing the risk of scarring in that sense. I think a lot of children with HADS will at some point in their lives end up needing catheterization. I don't know the prevalence of this. I have a little survey at the end. It should take about 5 minutes, and I will talk to you guys about that at the very end, but I'm curious to know how many of you guys have had to do this. But since the issue here, the big issue is the emptying phase, the catheterization is what really takes care of that. So in a lot of spina bifida patients, spinal cord patients, you also have the problem that the bladder is small, it's not holding. HADS patients seem to have a fine bladder. It's holding fine, especially if you give a little oxybutynin and help it hold more. It's the emptying that's the problem. So that's why catheterization is a way to overcome that. And that can either be done through the urethra or through a catheterizable channel that's created. A vesicostomy is a great option if you don't want to catheterize. You can't catheterize, the child won't let you catheterize. Maybe less risk of infection because you're not introducing a catheter all the time, so it can be a great option. Bladder augmentation you may see on the list of things that would be an option for neurogenic bladder patients. It's just not necessary in HADS patients usually because the bladder is not the problem, the urethra is. So this is what a vesicostomy is and looks like. So you can see this is like a side view, and you can see the bladder is this right here. And there's basically, you just pull it up to the skin and create a little stoma. So this is a little baby with a little stoma, and the urine just pours out continuously. There's no sphincter, there's no holding it there. They can't scar in, they can be too open or too tight. You may have to revise them. So there's definitely a risk with that. But if you need it, if the urine's not coming out, I will take this over the risk of pressure or the risk of recurrent urinary tract infections any day. An option to be dry in between catheterizations, but not have to catheterize through the urethra, which I do think is a very reasonable option for HADS patients in the right setting, is a channel where you take the appendix or a piece of small bowel and you create a little channel between the bladder and the belly button, and it's the same as a vesicostomy. Urine is coming out of it. It just doesn't do it by itself. You have to put the catheter in to get it out, but then you're not incontinent in a pull-up. This is the augmentation that I was talking about. If anybody mentions this to you, it is using a piece of bowel to make the bladder bigger to allow it to hold more. It is a huge operation with a lot of implications. And I have not come across a reason why this would be necessary in a HADS patient, but that doesn't mean it's not there. There could be a patient where if the bladder truly is not holding and it's become maybe damaged over time or contracted or small over time, or there are other things going on where it would be necessary to not only empty the bladder, but to allow the bladder to safely hold in between emptying. Bowel problems tends to be constipation, and it tends to be constipation that is related, like I said, more to the poor anal sphincter relaxation. So we have to think about that when we attack how we're going to treat it. Because they can actually, like if you're over treating it without taking that into consideration, you may end up with diarrhea and fecal incontinence, and it's really because we're not addressing kind of the root of the problem there. Definitely the same things that you would do in any child should be kind of first line treatments. I imagine that the variety, the severity is all over the map with HADS patients, like it is with everybody. Healthy bladder bowel behaviors, having the children sit on the toilet fairly regularly. I'm a huge believer in the use of the squatty potty to elevate the knees up while stooling. Stool softeners, laxatives, suppositories, enemas, or some kind of antegrade process where there's something, either a tube or a small stoma created at the beginning of the colon. So on the right hand side of the colon, we talked about the colon being like a question mark. So you put something here, so you could do a flush. So you could put a flush through either a tube or a stoma there, and that flushes out everything in the colon and out the bottom. But the issue in the HADS patients is that if their anal sphincter is the problem, this could potentially not fully take care of that. So that this is an option on the table for how to manage, but we have to always be thinking about where is the problem. So they would need a full gastroenterology assessment where they assess the colonic motility and the anal sphincter tone and address all aspects of it. But if you ever hear of this antegrade continence enema, this is the idea behind that. Sphincteric Botox, I think, can work wonders in patients with bowel problems who have HADS, because it is addressing the same thing that is the problem in the urinary sphincter. So the whole thing works together. The problem is with the pelvic floor, and it makes a lot of sense. It doesn't necessarily mean that it's something you'll do forever. Sometimes just weakening that muscle with Botox for a while is all it takes. Sometimes you can just space it out more, but I think it can really be quite miraculous, and should be in the toolbox of somebody treating HADS patients. And then especially if you get a kid who has been really constipated for a long time and the colon has been really stretched out, and it doesn't matter what you do to that anal sphincter, you could cut it open. If their colon, there's lost motility, things aren't moving along, then it can become very difficult to treat. And an ileostomy or a colostomy might be the better way to manage the patient long term. We have one publication just sharing our experience with our patients over in Dallas. I think we're running short on time, so I won't go through the details. You guys can type in my name in HADS and you can find it. It just shows basically all the problems that I talked about is what we see here. About half the patients that I see are actually managed with a vesicostomy, only one of which I created. So it's not that I'm like, making them left and right. They came to me that way, and I do think that they're very reasonable ways to manage. And yeah, so this is one of my little patients. I'll let you guys guess who. And I've been taking care of her since she was like 5 months old, maybe. So I've gotten to know you guys and her and learned about HADS from her. So thank you for that. That's a vesicostomy, her little vesicostomy that I created. She did urethral catheterization pretty much from the day I met her for years until she herself participated in the care and said, nope, I don't want this anymore, and would not let mom catheterize her anymore. So she got this little drainage option here, which works very well for her. I am told that an ostomy wrap over the pull-up while it is catching the urine works wonders. So yeah, there you go, passing on the information. So you can see it's pretty small and discreet. There we are, just hanging out in clinic, I think last week maybe. So she's in school and doing well, and I don't think little kids around her have to know that that's what she has for her urine. I have this little survey if you guys are interested in taking it for me. As you can see, it's pretty short, shouldn't take but about 5 minutes, and it's super just kind of to the point, just the things that I'm curious to know. How many of you have been offered these tests that I talked about, and what problems do the kids have? I think it'd be really nice to put out a little abstract at a urology meeting that basically says just that, like, this is the prevalence of urinary tract infections in kids is this, and these are their issues, and these are our recommendations, so that I can publicize it to the urologists, and they know how to better take care of you guys and be of assistance with your children's issues. This is the little QR code for the survey. So if you can leave it up on the screen so people can capture it, that would be awesome. If not, Siobhan Barney has it on her phone, and I can text it to anybody else who wants it. Yeah, if I get a significant number of these, I can put this data together and get it back out to you guys ASAP. I have 2 fellows working with me who I'm sure would love nothing more to do than to crunch some numbers this weekend. So send them over. Yeah, I'm sorry if I ran into your lunch a little bit, but I am totally happy to stay here and answer as many questions as you want. So if everybody wants to like mosey on to lunch, but if y'all want to stay, I don't know, if you want to come to the podium or ask questions in the chat, or however you want to do, I'm happy to answer questions as personal or impersonal as you'd like.
Hi, I'm Deepa. You had mentioned the difficulty initiating a stream, initiating a void. So I wanted to ask, with my child, we've had a history of urological issues that have since improved over time. She's now 6. One thing we've noticed is that she's able to empty, but she only seems to be able to initiate a void when her bladder is almost full, like, which is mostly full, at least like 2/3 to full, which is, different from other kids where, you can do things like timed voiding, which we can't. And I was curious to know, how much of a concern do you think that is, in the absence of some of the more serious issues like VUR or high pressures in the bladder, or even incontinence because she's toilet trained. So that's one question. The other question I had was, what do we know about the progression of the HADS bladder? I mean, over time, do children develop a better ability to relax their sphincter? Do we know if the nerve signals improve over time, or, we see improvement in other areas for HADS kids? And I was curious how that works, or what we know so far about how the bladder performs over time.
Yeah, so your first question, in the absence of other issues, I would not be too concerned about what she's doing, but I would say the absence of other issues, I would love to also see an ultrasound. So if she hasn't had an ultrasound, I might just ask somebody to put that order in and just get that done at some point, so you make sure that you're not missing something, because I have seen kids where they're able to look like they're doing okay and stay dry and they're not getting infections, but they are having hydronephrosis. So they're having dilation in the kidneys. And like I said, that can be either because they're straight up pushing urine up there to cause that dilation, or because the bladder is kind of high pressure and is transducing the pressure and you get dilation. And that over time will hurt kidneys. But in the setting of a normal renal ultrasound, even if she does have a little bit of a high pressure bladder, or she has to get to a higher pressure in order to avoid, like, I promise you, if we got a urodynamics on her, I doubt it would be like perfectly normal. That's okay. What you care is she doing something with her voiding to hurt herself, right? So if she's not having dilation in the kidneys, she's not having infections, she has to get pretty full in order to overcome that tight sphincter. She has to kind of get a little bit of a higher pressure in the bladder in order to overcome the sphincter. But we don't have any of the concerning things. I would kind of be happy with that and carry on. And I suspect as she gets older, you may be able to do a little bit more with the time. But even if you don't, if there's no deterioration, I would say she's just kind of on a milder end of the spectrum, and that's fantastic. Just kind of keep an eye on things, and maybe, I don't know, every year or two, just get an ultrasound just to kind of be sure. It just kind of scares me to completely take my eyes off the situation. And just kind of all kinds of kids who a lot of times don't seem to have problems, but you know, the way they're kind of avoiding, you know, like Down syndrome's kids, for example, they seem to do well most of the time, but once in a while, you'll get them where they do this dysfunctional voiding a lot, and they do it to a degree where they really do start to affect their kidneys. So I think just kind of complex kids in my practice, I tend to just keep an eye on with renal ultrasounds. I think yeah.
Sorry, I was just going to say, yes, no, she is actually quite closely monitored, because when she was a baby, we did have, you know, this issue with the dyssynergia, and she did have high reflux, and since then it's been managed. And as she's grown older, what we found is that she's now in very minimal kind of mirror background, just resulting from some of the issues in the past. But what we've seen from the urodynamics is that she is able to empty. She doesn't have high pressures. She has a clean ultrasound, still mild trabeculation on her bladder wall, but that's it. And the kind of main thing we see is that she's not able to pee on demand.
So, yeah. I mean, I think that all just kind of fits with just a little bit of a mild variant. You know, that little bit of trabeculation says maybe like some slight little bit of overactivity or high pressure, but obviously not too much if you're not seeing anything significant. The mirror background is probably like you said, a whiff of mirror background to kind of calm down some spasticity. That may in and of itself make it a little bit more difficult to void, but it's calming down higher pressure type stuff that could be problematic. So I think if it's working for you guys, I don't think I would necessarily worry about just that she has to get to that level to void, because it sounds like all the things that would be concerning are being really closely monitored. So I would take it. And I feel like if you try to deviate too much to, you know, if you try to get it to a place where she's going to void easier, which you might be able to do, you might see other things you don't want to see, like incontinence, you know. So I think as long as she's not doing anything dangerous, but she's dry and she's not getting infections and her ultrasound's good, I would take it. I don't have a great sense for the progression of disease yet, as far as kind of how things progress. If I guess I don't know. I don't know how I'm trying to phrase this exactly, but I'm more concerned with progression if things are not addressed. So I guess I could see things get continuously worse over the years if things are not addressed. So like if you do have a child who has a really high pressure sphincter and you do not address it with Flomax, with catheterization, with whatever is needed, I do see that going towards bladder deterioration in any number of ways. If things are addressed proper, because it's like if you address things as they come to you, you may see benefit, not necessarily of natural disease progression, but just of the fact that you're kind of taking care of problems. Like if your child developed, you know, through the dyssynergia in infancy and all that, developed some trabeculation and high pressure bladder, which is what I would expect. And now you're addressing it with myrbetriq and you're keeping an eye on this, that, and the other, and you're not getting infections. You may see just kind of a better appearance of the bladder and of the genitourinary tract and of her ability over time. But I don't know that that's like the condition getting better as much as you're responding to things and you're seeing you're in a better place because you responded appropriately. I don't know.
So you don't think the underlying issue of the DSD by itself over age might improve, or the sort of body learns to better coordinate it?
I think that would be super patient specific. I don't have a good enough answer to say like overall you can expect this, because I think it has a lot to do with each, like where each child starts anatomically, what their ability is as far as you being able to communicate with them and then being able to follow instructions. And this is the sort of thing where what they do kind of matters. You know what I mean? Like even if you have a child who doesn't have HADS, but they hold all the time, they will head in one direction versus you have a child who does not hold all the time, they will head in another direction and literally anatomically look different 5 years later. So I think that it's too multifactorial for me to have a good answer for what to expect as far as like the disease itself getting better versus all I can tell you to do is respond really closely to what hand you're dealt, sort of, and that should put you in the best place that you can end up with.
We had a question from Zoom, Dr. Stanisel.
Yeah.
Comes from Julie Dernbeck, based out of St. Louis. Can you clarify if there are any times vesicoureteral reflux or VUR occurs in HADS patients without neurogenic bladder / DSD? And then a second part of the question, is there any indication this can improve over time, like other neurological symptoms over time, i.e. with brain development? And lastly, she asks, is there any long-term hope for treatment besides treating the symptoms?
Okay, so reflux without any sign of neurogenic bladder in a HADS patient, I would be incredibly skeptical of. Incredibly skeptical. Reflux in the general population is about 17%, so it's not low. So the chance of just like anybody having a reflux is pretty high, 17%, but the clinical significance of it is usually not particularly significant. Now, if you have a kid with UTIs, then it becomes more significant. But if you have a HADS child with reflux, why did we find out that that child had reflux? Because the child was getting infections and we checked a VCUG. And what I suppose what somebody would have to prove to me is that on a urodynamic test, there is like perfectly low pressure filling the whole way. There's no overspasticity, and either on permission to void or when the bladder is full, there's a contraction in the bladder with a relaxation in the sphincter, and the bladder empties fully, and there's reflux. Okay, so the reflux does seem to be either a primary, like it occurred, or it occurred through some HADS type physiology, but the reflux is our primary concern right now. I would just be very skeptical. If somebody told me like, well, I think he just has reflux or she just has reflux, I would be like, I need everything, because I don't believe that. Like I imagine that if a HADS child has reflux, there's probably some degree of typical HADS bladder urethral stuff there that is contributing, or is that at least going to make your life worse. Like if you try to fix your reflux, you're more likely to fail because they're just going to pop it back open because of how they void. So I'd be very, very careful with that. What was the second question?
Second question is there any indication this can improve over time, like other neurological symptoms over time, i.e. with brain development?
Again, I don't have enough of a sense of that to give you like a blanket statement like this can get better. I think I would continue to focus on not like, I almost feel like saying something like that makes it feel like we're not responding to something, and that's what I want to make sure we don't do. Like if there's something that you should respond to, I would just respond to it. I would not wait for it to get better. Like if you have reflux and urinary tract infection and the bladder is not having a very good squeeze and you need a way to drain it, like I would focus on figuring out how to get the drainage, not wait for the child to get better. I would be aggressive because the repercussions are significant, and I wouldn't want to give a hope. I would want to just focus on addressing the issue at hand, I suppose. I think my sense is that if things get better, it is more likely to be because we have responded, like the bladder can get better because you've drained it, because you've treated it with the medications that it needed, rather than the other way around, like their neurological condition got better. The urinary tract is very finicky and very sensitive. So I think I would not not focus on the answer to that question and rather focus on what is going on today. What do we need to do to optimize the outcome for this urinary tract, if that makes sense.
Copy.
Yeah, like so the example, the patient that I was talking about, that's, my first patient, when I met her, she was 5 months old and the bladder looked awful. Like it was super trabeculated, super thick walled, moderate to high degree of hydronephrosis, of dilation in the kidneys, and of reflux. And all of that improved. There's no dilation in the kidneys. There's no reflux. There's no urinary tract infections. All that stuff looks fantastic, but I don't think the neurological condition got better. I think we got to work on getting the bladder drained. And I don't know what her future holds, as far as now she has a vesicostomy, and if in the future we could try to see what would happen if we closed that vesicostomy. There are ways to test that. You can do urodynamics testing. You can put a Mickey button in the vesicostomy to sort of occlude it and cap it, but and still have it for drainage, but give her a chance to void on her own. I would not be against any of that. It would just have to be done judiciously and respond to what you're given, rather than, kind of hang on to the hope that it naturally gets better by itself.
Copy. And then she asks, is there any long-term hope for treatment besides treating the symptoms?
Not from a urological standpoint. From a urological standpoint, I don't see us urologically doing something different. I think the hope there lies in the gene therapies and those sorts of things. I think urologically, all I can do is respond to the urinary tract in front of me and address it in the best way that I know how, to protect the kidneys and to improve social continence.
Copy. Okay. Yeah. Deepa Handy has another question here. Oh,
yeah.
We've got a question. Here we go.
I have one that's hopefully pretty straightforward, simple. The treatments, as far as like the urinary retention, is there a Botox treatment for that? I understand it might be more difficult since the sphincter is actually buried and not like right there at the surface, like the anal sphincter. But is there a Botox treatment for that?
Excellent question. I meant to include something about that and it completely slipped my mind. So you're on me. So it is an option. It's just not a good option. Okay. Because we've dealt with this problem with the detrusor sphincter dyssynergia, things not talking to each other for a variety of reasons forever, not just in HADS patients. So spinal cord injury patients and neurogenic bladder patients in general, we've tried different things. So like back in the day, they've gone to, if it's somebody where they sort of have the worst of both worlds because they have this tight sphincter, so they can't empty fully. Now they're really full, so they get overflow incontinence. So not only can they not pee well, and they're sitting there full and causing all those problems to themselves because of it, but they're also in a pull-up. So it's complete incontinence, they're not dry, and they're in trouble because their bladder's full. So one of the things that they did decades and decades ago, they used to cut the sphincter, try to completely cut it open to just let these people be like at least freely incontinent. So they're just pouring urine out into a pull-up. So they're still wet, but they're at least protecting their kidneys. And even that didn't work well. It's like very unreliable. It's actually hard to cut the sphincter reliably to where you can get that complete incontinence. And in spite of, anytime I'm working with a resident, I'm always like telling them, be careful with the sphincter, be careful with the sphincter. But really, I may be overdoing that because we've proven it's actually really hard to cut the sphincter enough to cause that incontinence. So, and then it's a bloody mess, and, just it did not work as well as we wanted it to. And then Botox is even worse. So if you can imagine, just like straight up, and you know where to cut, we know anatomy, and we're still having a hard time getting these people to be completely incontinent. Botox doesn't even work that well. So it's hard to know where to inject it, and the stakes are higher. So if you say I injected it, I took somebody and I was like, I'm going to try to Botox their urethra. And, you know, I kind of got lucky and I kind of injected, got some good shots in, you know, and I did pretty good. But, and then they, you know, they pick up their voiding and things are looking good. They're having some ultrasound improvement. The only way to inject them again would be to take them back to the operating room, and that would have to be 3 to 6 months later, 3 to 9 months later, depending on the person. They say that Botox in the bladder can last like 6 months to a year, maybe 9 months, something like that. I don't know. I think it lasts even less then, and they have to go to the operating room, and you'd have to like replicate your injections, which would be really hard because it just kind of goes, can inject it and it can kind of go wherever it wants. And then that's the problem with what I'm saying with progression is if they're on the right path towards, okay, now we've relieved some of the obstruction, we've given them some relief, the sphincter is not so tight so that they can void past the sphincter, so the bladder can catch a little bit of a break and the trabeculation can improve. The muscle of the bladder is not like working so hard, and now like your next injection you didn't do as good of a job, now it's a setback, now the bladder is going to have to work hard again. So I haven't tried it. I don't think it's like inconceivable that it would be an option because it addresses your pathology, right? You're addressing the urethral tightness. I just think it is a dangerous game to play. And the stakes are high. Like if you don't get it right that time, you're worsening your bladder, and you're potentially going to end up with febrile urinary tract infection 1 month after your Botox injection that didn't go that well, and then you got your DMSA scan 2 months after that, and now it looks like somebody took a bite out of the left kidney. The stakes are really high, you know. So you could cause problems by not providing adequate treatment. So it's definitely, I would say it's not an option. I just am skeptical about the efficacy, the longevity, and the repercussions of it.
All right, thank you.
Hi, it's me again, Deepa. I was interested in your comment about being very careful about anticholinergics and mirabegron, because obviously that's not the filling phase is not the issue, or the bladder itself, you know, it's just a sphincter. I had an interesting conversation with our urology team where they're not particularly, you know, they don't know HADS bladders, but they because we had a regimen previously when my daughter was a baby of basically the anticholinergics and regular CIC, which we now scale back on, and now she is doing quite well. She empties well, and we do a cath once a day, which we were told is not even really required, but she is on half the minimum dose of mirabegron. However, our urology team is quite worried about taking her off mirabegron at any time, just because when she was a baby, when she was younger, she had high pressures, which was caused by the initial DSD, which seems to have improved. And they were like, no, neurogenic bladders do not improve. You know, we're really worried if she was ever off anticholinergics, her high pressures would return. I'm curious to, like, in the kind of understanding of the HADS bladder, if the underlying issue of the DSD is, I'm not saying completely gone, but she is able to empty with a full bladder. If that's the issue, is there any reason to follow the sort of just the conservative traditional path of bladder management with staying on the anticholinergics? Like if she was taken off and trialed and is there a reason to be concerned that the bladder itself would continue to sort of deteriorate or not deteriorate, return to high pressures as before, or what have you seen in that regard?
Yeah, so I think that her high pressure bladder was a result of her dyssynergia, which, as you're saying, seems to have improved. Now you are doing that one catheter for her. I don't know. Again, I'm with you. I don't know what that's adding. I don't know about catheterization.
It doesn't add much. It's just because it's been part of her routine and we were afraid to take it off.
Yeah.
It'd be hard to restart it.
Do you get a lot out? Do you get a lot out when you catheter?
No, it sometimes varies, but usually not very much, between 20 to 30 mils.
Oh, okay.
I mean, she has a big bladder size at this point, so it's like 250.
Yeah. So it really may not be necessary, just like you said.
Yeah.
Yeah. So, I don't know. I don't know that I feel as strongly as your urology team, does, but, about trying her off of the mirabegron. But I do think that what you're medicating with the mirabegron is the residual effect of the dyssynergia before. And, that it may be that, like you're just in this like steady state where, whatever, kind of the way the universe is coming together for you guys right now. She gets to this certain pressure in her bladder, this certain fill level, and that's what it takes to overcome her sphincter and to empty past that sphincter, and, if you, I guess like my concern would be, I'd be afraid of disrupting what you have going on because it sounds pretty good. That would be the main thing, because I think, I bet she still has, even if you can't see it on imaging, I can't imagine that she doesn't have like some subtle little bit of dyssynergia or some subtle little bit of like, she's not, like you're saying, she's not peeing when she has 50 or 100 in there. She has to get pretty full. So I think she still holds her sphincter pretty tight. It's not dyssynergia, but she holds it pretty tight until she gets to a certain pressure to overcome it. So it's still kind of a tighter pelvic floor and a tighter sphincter, even if you don't want to label it as dyssynergia. So she has to get to this like certain pressure, and then that's when she overcomes it. And I don't know if the little bit of mirabegron that she's on is just enough to not cause her bladder to go like, too tight from what it's having to do to overcome that. Like, it just seems like a pretty sweet deal you have. So I probably wouldn't mess with it. But I think if I was, I don't know, in space and maybe if I just like saw the picture and I didn't know the history or something, I'd probably be more inclined to try Flomax to help her void.
Yeah.
But that would be if you had a problem you're trying to get me to fix, but like you don't have a problem you're trying to get me to fix. So I'd be hesitant to mess with anything because it's working, But yeah, I guess I wouldn't be as against trying her off the mirabegron as long as you're keeping a close eye on the situation. But I understand the thought process behind it. Like you're trying not to get her bladder get too trabeculated and too high pressure because you were in trouble when she did. But if she's got a bladder of 250 and she's 6 years old now, that's a big bladder. I think she's still overcoming some degree of pelvic floor overactivity there. So I think she needs to be kept a close eye on and react to what she gives you. If she starts to go in the wrong direction, then you may need to consider more from focusing a little bit more on the emptying phase and, go from there.
Okay, gotcha. It just seems that the urology team I guess because they're more used to dealing with the anticholinergic CIC kind of method, and they're very scared of kind of moving away. Whereas that is obviously, for a child, and especially if you're sort of showing signs of improvement, like you were saying, I was thinking, would it not make more sense to just put her on Flomax and take her off CIC and mirabegron altogether and give her?
Physiologically, yes. Realistically, I'm scared because you're doing well, Okay. But I am very much with them that being used to treating the spina bifida population, like I would never tell a spina bifida family like, oh, we can be on catheterization for a while in CIC and things will get better. Like I'm like, no, you need to prepare. This is your life now, So I think we're very much used to in that population not expecting it to get better, and the ways in which it gets better, very much so. Sure, the bladder looks better on urodynamics because we're treating it. Not because it magically looks better and we're going to stop this, that, or the other. So I do think that probably people are pulling a lot of that to how they think about HADs. And I don't think it's necessarily it's not going to be harmful. If anything, it's going to cause people to be like overprotective of them. I think I'm okay with that. I'd rather people be more overprotective urologically than not. So but there are some differences here. There are some differences. The main issue in a lot of spina bifida patients is the bladder, not the urethra. So this is different. So you're having to react to how the bladder behaves, and the bladder can behave abnormally.